Well, it's a pleasure to be speaking to this year's HIV and hepatitis meeting, also including some COVID, and I'm here to provide you with a brief update on small molecules and monoclonal antibodies as antiviral therapy for COVID-19. These are my disclosures. For COVID antiviral therapeutics, there are two classes of drugs that I'll be speaking about. These are the RNA-dependent RNA polymerase inhibitors, and I'll really only talk about remdesivir, which is an approved drug in the US and has emergency use authorization in many countries. I won't speak about molnupiravir or AT-527, which are still in clinical trials. I'll also then focus on monoclonal antibodies, including combinations of bamlanivimab and endivimab, casirivimab and imdevimab, and the single monoclonal antibody sotrovimab. So let's start by talking about remdesivir. As I'm sure you are all aware, remdesivir is an RNA-dependent RNA polymerase inhibitor with in vitro activity against a wide range of RNA viruses, including Ebola, the original SARS, MERS, and SARS-CoV-2. Interestingly, in a phase 3 clinical trial done now several years ago, it was proven to be inferior to broadly neutralizing antibodies against Ebola. But it is effective against MERS in murine and non-human primate models and has been shown to be effective against SARS-CoV-2 in non-human primate models as well. And as you can see in the figure on the right, in vitro assays show that SARS-CoV-2 has an EC50 of about just under 1 micromolar with the remdesivir. So the first randomized clinical trial to show efficacy of remdesivir was the ACTT-1 study. This was a placebo-controlled, double-blind RCT in hospitalized adults with COVID-19 pneumonia. Participants were randomized evenly to receive remdesivir or placebo, with the primary endpoint being time to recovery within 28 days. And the preliminary analysis was conducted after there were just over 600 recoveries attained. As you can see in panel A, overall, there was a significantly greater proportion of individuals who recovered on remdesivir compared to in the placebo arm. They recovered faster, and that was statistically significant. However, if you stratify the participants by severity of disease at study entry, it's less clear that there's a significant benefit for those who are not yet sick enough to require supplemental oxygen, whereas clearly there's a big separation between those who received remdesivir or placebo among participants receiving supplemental oxygen, but no difference for those who were sicker, that is, those who needed either high flow oxygen or invasive mechanical ventilation. Now, there were several other studies that suggested some benefit, and I don't have time to go through them all, but then the Solidarity study, which was conducted under the auspices of the WHO, showed no benefit, but with an important difference here. The endpoint is mortality. So there was no survival advantage for individuals randomized to remdesivir as compared to the standard of care control. And that was true whether participants were stratified by age or by ventilatory status, although there was clearly a worse outcome among those who were ventilated than those not ventilated. And overall, there was really no significant benefit. Subsequently, Kaka and colleagues conducted a meta-analysis of several different remdesivir clinical trials and came to the conclusion that there is some benefit, although the magnitude of the benefit may be modest depending on the endpoint explored. So this slide shows the different analyses focusing on mortality. You can see that overall, there was just about a 7% reduction in mortality, and that just failed to achieve statistical significance. This analysis is heavily weighted by the Solidarity study, which had the largest number of participants. And then if you look at, if you include additional studies, or if you stratify by oxygen requirement at baseline, again, as we saw in the ACT-1 study, if no oxygen was required, there's no significant benefit. However, those who required supplemental oxygen but were not yet ventilated, there's about a 20% reduction in mortality, and that was statistically significant. However, for those already ventilated or on ECMO at study entry, there was no benefit and perhaps a trend towards worse outcome. Looking at non-mortality endpoints for the proportion recovered, and here the side of the line shifts because now having a greater chance of recovery puts you to the right side and favors remdesivir. And we can see that there's about a 10% benefit across these three trials that does achieve statistical significance. Sorry to switch back and forth, but now progression to mechanical ventilation or ECMO, so a lower odds means you're better and favors remdesivir now on the left side of the line. And that is the case here again, about a 30% reduction in progression towards mechanical ventilation or ECMO for those who received remdesivir, and that again is statistically significant. Likewise, a lower incidence of severe adverse events. Now, most recently, and this is just in the last few days before preparing this videotape for the HIV and hepatitis meeting, the Discovery study, which is another platform trial done in Europe, was reported in the Lancet Infectious Disease. And this study randomized participants to remdesivir, standard of care, or other treatments. And here we're only looking at the remdesivir versus standard of care outcomes. And you can see by the distribution of disease severity, they were well matched at baseline. Here, red is worse than pink or beige or green. But at day 15 and at day 29, there is no significant difference in distribution using the WHO 7-point ordinal scale. You can see the odds ratio is just about 1 at day 15 and only slightly greater than 1 at day 29, failing to achieve significance. However, as we saw in the meta-analysis, if we look at progression to the need for invasive mechanical ventilation, that is for those not already on a ventilator at randomization, or progression to ECMO or death by day 29, there was about a 35% reduction that did achieve statistical significance. I'm sorry, there's a decimal point missing there, but there was no mortality advantage. So where does that leave us with remdesivir? Well, clearly the results are mixed, and it may very well depend on the exact patient population being treated and the time from symptom onset to the initiation of remdesivir therapy. Overall, it appears that there probably is a benefit of remdesivir, but it is certainly not a panacea. Well, let's look at SARS-CoV-2 monoclonal antibodies. These monoclonal antibodies are able to neutralize SARS-CoV-2 by targeting the S protein. They can be genetically engineered to combine multiple specificities or by modifying the Fc domain to extend half-life. And they have potential utility for treatment and prevention of COVID-19. Today, I'll only be speaking about their use as therapeutics, not as preventive agents. This study, this slide shows two different studies, the phase 3 trial of bamlanivimab plus etazivimab, and on the left, and then on the right, the phase 3 trial of casirivimab and imdevimab. And for both of these, what you see is a significant reduction in disease progression. These were studies conducted in outpatients who had symptomatic PCR-confirmed SARS-CoV-2 infection and fell into a high-risk category. That is, they were age 65 or older or had one or more comorbidities. And the endpoints were progression to needing hospitalization or an emergency room visit or death. And you can see there was a significant reduction in progression in the bamlanivimab etazivimab study, as well as significant reductions in the casirivimab imdevimab study. In this trial, two different doses were studied, 1,200 milligrams and 2,400 milligrams. All of these were done by intravenous infusion, although subsequently it's been demonstrated that subcutaneous administration of casirivimab imdevimab leads to similar results and has similar pharmacokinetics, although those are studies done in smaller numbers of participants. And although the EUA for cas and imdevimab has been expanded to include sub-Q administration, the preference is to do intravenous administration where feasible and reserve sub-Q administration to settings in which implementation challenges of intravenous administration would limit the availability of these beneficial antibodies. Now, sotrovimab is an antibody that's been studied on its own. We don't have as comprehensive data because nothing yet has been published and there isn't a manuscript posted to medRxiv. But here you see in the fact sheet provided to healthcare providers for their emergency use authorization, a study of about 600 participants, same general principle as with the other antibodies we've discussed, a substantial reduction here, 85% reduction in the risk of progression from being outpatient to requiring hospitalization for acute management or progression to a worse outcome. There were fortunately virtually no deaths, only one in the placebo arm and none in the sotrovimab arm, so really can't comment on the effect on mortality, except to say that if you're preventing people from progressing, you're obviously preventing people from having worse outcomes. This study is unique among the antibody studies in demonstrating an advantage of these antibodies in hospitalized patients, because it's important to mention that by and large, these antibodies have failed to show benefit once people become hospitalized, mostly because by that point, people already have their own antibody response. And in that setting, it's hard to show any additional advantage of exogenous antibody administration. One difference is in people who have not yet made antibodies, even though they are hospitalized. And those people fall into two groups, those who have very rapid progression and may get hospitalized prior to a humoral response, or more importantly, those who are unable to make antibodies, particularly because they are receiving immunosuppressive therapy or have recently received anti-CD20 therapy for the treatment of lymphomas or certain inflammatory diseases. And so here you see REGEN-COV is the combination of casirivimab and imdevimab, that among those who were seropositive, there is no difference in mortality, but there is an impressive mortality difference, a 20% reduction in mortality in hospitalized patients with COVID-19 who are still seronegative, where the casirivimab plus imdevimab is highly significantly superior to usual care. And you can see the tree plots here, in this forest plot, I'm sorry, that benefit was true whether people were already mechanically ventilated or not, and it was true for, I'm sorry, it was true for the endpoint of death within 28 days, greater proportion of people discharged alive, and progression to mechanical ventilation. So in all cases, a benefit for the seronegative, but not for the seropositive. Now, a concern about these antibodies is emergence of resistance. The alpha variant remains susceptible to all the antibodies, but not so the beta and the gamma variants, particularly these variants that carry an E484K mutation in combination with the 501Y substitution. And those lead to significant reductions in neutralizability by bamlanivimab and even affect the neutralizability by the combination of bamlanivimab and etesivimab. That had led to the temporary suspension of distribution of this combination in the United States. However, the Delta variant is fully susceptible to by this pair of antibodies. And so now that Delta is essentially the only strain circulating in the United States, nearly 100% of cases currently are Delta, as is the case in many parts of the world. These antibodies are once again being used. By contrast, casirivimab and imdevimab remain effective against the alpha, beta, and gamma variants, as well as some of these other less notable variants, and remains active against Delta. Likewise, the sotrovimab, which you remember is a single monoclonal antibody, retains good activity against the beta and the gamma variant, as well as these other minor variants. And here you see the Delta variant. This slide, just to very briefly mention that bamlanivimab and the combination of casirivimab, imdevimab can be used to protect exposed individuals from developing COVID-19. The bamlanivimab study done in nursing home residents or residents of long-term care facilities, and the casirivimab, imdevimab study done in household contexts. And you can see the significant benefit as post-exposure prophylaxis for these antibodies. Because bamlanivimab is not available on its own, it currently has no approval since there's no combination study, but casirivimab and imdevimab in the United States are approved under an emergency use authorization for post-exposure prophylaxis. So to conclude, remdesivir and monoclonal neutralizing antibodies may play a role in the treatment of symptomatic COVID-19. Treatment is most effective when initiated early in disease. The potential role of mAbs as post-exposure prophylaxis is very promising, but a logistical challenge to implement. And then therapeutics will continue to have a role even in the setting of widespread vaccination, because there will be some people who fail to respond to vaccination, and there will continue to be breakthrough cases. Thanks very much for your attention.